you see the area of the nodular lesion with enhancing quite strongly. Okay, of course, at the finger. So whenever you do MRI, you do only one finger, and you must magnify the lesion or magnify the finger by using the small FOV, field of view. So you scan one finger or a few finger only, make the image bigger, then you can see clearly because the lesion is very small. It's very small, but it's very painful and it's caused many problems. Okay, so that's good. We have the ultrasound. Yes. Then I think if possible, we can suggest the patient for MRI scan. That's it. This is one very good pickup, a very good pickup of the disease. And so this one, the MRI is not done yet. Is this correct? The MRI not done yet, right? Okay. So never mind. Can we see from the beginning? Yeah, we skip. We show one by one. One by one. All right. All right. So review again, and then this side of the disease is quite uncommon. Sometimes you will see the patient, but very rarely the patient will have ultrasound. I am very surprised that why they send the patient for ultrasound. Usually they do the MRI scan. So what is the reason why they do ultrasound? Yes, you can pick up the lesion under ultrasound. Whenever you think of that, when you think of the lesion, you think of the glomus tumor, then you scan, then you can pick up. Otherwise, if ultrasound, if you don't think of this type of lesion, then it's quite difficult. But whenever I think that when you do ultrasound, you already think of the diagnosis. You guess already, hear the diagnosis, you have the diagnosis before you do ultrasound scan. The majority of the patient come to us with the problem with the nail. Usually the patient experience MRI scan. So that's why I'm a little bit surprised that the patient only do ultrasound without any MRI scan. This is okay. Very good of you to pick up the lesion under ultrasound. That is really nice. So it's very simple. The lesion is a vascular nodule, nodular and vascular lesion below and beneath the fingernail, and this can cause is very painful and is sensitive to temperature, and when you press the patient also very painful. Also when you press like this, the patient very painful, and there's a broken of the nail, change of discoloration, the color only change, and also sometimes bleed whenever it's broken. And the patient have the problem long time, in very long range of time, and the patient may apply a lot of medication, topical medication, and doesn't resolve, and the patient come, and at the time you should think of glomus tumor. I think that is the common problem is a common problem with the fingernail that lasts in a long time and cannot settle with medication or topical ointment. And when the patient come to us, just think of that and scan and do ultrasound. You can, yes. MRI, yes. And whenever you do MRI, you need to give contrast. So the lesion will have the appearance in the pictures in the MRI, on the MRI images. This is hypointense on T1 weighted and probably a little bit moderate to hyperintense on T1, T2 weighted. So hypointense on T1 weighted and hyperintense on T2 weighted. And when you give contrast media, when you give contrast administration, then the lesion enhance very strongly with nodular lesion, enhancing very vividly. Okay, you can show again the MRI. Yes. Can you show again the MRI? Yes. So the last image, is it the T1 weighted contrast on cytopause? Yeah, contrast fast saturated. Yes, on the last image we have the T1 contrast, T1 weighted fat saturation, and with contrast and contrast administration. This one, yeah, okay. You see the bone. This lesion, I'm not sure whether there is any scalloping of the bone of the distal phalanx, the bone. There's a disruption, the abrupt change of the axis of the bone of the phalanx. Maybe because of the slide, because of the oblique cut. So there's disruption of the bone, you see. I'm not sure whether there is any scalloping of the lesion into the bone. Maybe because that is one of the features, because the lesion will cause the positive pressure into the bone, and may cause a scalloping. It's benign. It's the benign lesion, but in time, you can call indentation into the bone. Can we see again the radiograph, the X-ray? Yes. All right. To me, yeah, it's difficult to say it is abnormal. Yeah, quite, because you already got the finding on ultrasound, so you review back the X-ray, and you can see, you can tell. But with the initially, if you have the radiograph, quite difficult. But if there is mortal change of the bone, of the distal phalanx, of the bone matrix, you see will be dot of translucent on the area that the bone is inhomogeneous density of the distal phalanx, or the area of the bone inhomogeneity, or the differences between the cortex and the medulla and the body of the distal phalanx, the bone. And you will see that area is suggestive only any lesion, and to suggest any lesion of bone erosion only, or bone absorption only. Anytime radiograph is difficult for you to tell, oh, this one is a glomus tumor. That's difficult because this type of lesion in the bone on radiograph, it may be caused by many other different entity, many other disease can cause a bone change. So on radiograph, usually you don't see any change. You don't see any obvious change. Quite difficult for you to tell on radiograph. But if you see any change of the bone at the distal phalanx adjacent to the finger, the nail, then you may think of that. You may think of that. Okay, so under radiograph, you will describe the change of the bone, and after that, you can suggest the ultrasound, and you suggest the MRI. Okay, so, and you can combine with the clinical symptom. And then you may have the suggestion. You may suggest for ultrasound, you can do MRI, and you see the nodular vascular lesion. Okay, thank you very much. Very good case, very good pickup.
Thank you, everyone.